So our ABCD approach is A is for airway and C spine stabilization.
Hello everyone, welcome to Mediclave 2023. I am Sneha, a final year medical student from SABB MCRI Bangalore. Today we have Dr. Umar Sheikh, emergency medicine resident working at Max SHB Hospitals, Delhi. And today we'll be talking about trauma. Over to you, sir.
Yeah, good evening. Sorry for this late session today. Emergency medicine, I'll be talking about trauma and approach to a patient in emergency medicine. So we have different approaches to patients, like the patient from medicine, they go with systemic examination, how they go with that, name, age, sex, along with history of present illness, then past history. And there is a totally different approach for the patients in emergency medicine. I'll discuss about it and more, I'll talk about trauma in detail. So if you have any questions, you can please ask right away.
You can go ahead, sir.
Trauma, let me talk about trauma and approach to patients in emergency medicine. Uh, Trauma is one of the most important causes, the most biggest cause basically of death worldwide. So in the world, it rates at at number six killers as in mortality, trauma. In India, we have a lot of burden of trauma in the country. So around 30% of patients who come with trauma end up being dead. Initially, we did not have the branch. We did not have a proper branch that used to deal with the trauma. There used to be some emergency medicine EMO who used to deal with all kinds of trauma, not specialized in it. But as the time advanced in foreign, we had emergency medicine, and then it was brought to India very late. But yeah, it is there now. So as I talked about trauma, that is the number one is the RTAs, which rate every minute around one person it's goes through an RTA in the country, and every 3.76 minutes a person dies of RTA. So literally right now, when we're talking, there will be person somewhere who will be having an RTA. So, as I said, that the approach to a patient in emergency medicine is quite different than other branches like medicine, ortho, or something. So, as an emergency medicine, if there is a emergency physician, if there is a patient who comes to me with a trauma, I will start with the very basic protocol. So, initially, there was no protocol for all the people. So, but now there was the doctor named Dr. Steiner. So this is, I will tell you a story about ATLS. That is how, ATLS stands for Advanced Trauma Life Support. So there was Dr. Steiner, who was a surgeon in US, his family met an accident. And as his family met an accident, they went to the doctor nearby, and his wife and his children died. And luckily he survived. Because of that, he saw that how the case was mismanaged. So he started working on a protocolized approach, how to deal with an emergency physician, emergency patient. And then that protocolized approach was brought throughout a lot of countries. Like now, more than 150 countries have that protocolized approach. In fact, it was also brought in India, ATLS, the ATLS. So we also have an ATLS course that deals how we deal with the trauma. So the approach to a patient that comes to the emergency with trauma is starts with it's an ABCDE approach. So it's a we call it the primary survey. So once the patient just enters the emergency, so we have to start with the primary survey. So the primary survey deals with how the patient comes to us and how is it. So first thing we see, as an emergency physician, in all the patients that come to us, we deal with a very protocolized approach so that we do not miss on something. It is a bit different from the medicine people, as I said, different from the gynae people. We deal with the whole patient as a whole. So our ABCD approach is A is for airway and C spine stabilization. So airway, how do we check the airway? Is the patient talking? So suppose there is a patient that comes to us. He's talking properly in clear words. So that means his airway is patent. So when I talk about airway is patent, that means the tract, airway tract. So I'm not talking about the breathing and all, but I'm talking about the tract. Airway tract is patient. So he does not have any choking, and he's able to say he does not have any broken teeth in the mouth. He does not have any bleeding gums. He's not, he's not having hematemesis. He's not having one important job is to maintain the airway, because if you are not able to maintain the patient will expire within 5 minutes. So that is the most important cause. That is the most important cause of death when the patient comes and he has his airway is not protected. So he might end up being dead. As I told about airway, so airway is if the patient is talking or even crying. So we see a baby is coming to us, he's crying. So we're very happy that it's a trauma and he's crying. That means his airway is patent. So our job is to check the airway. We just open the mouth and see if there is any foreign body, any tooth dissolvement. So these things, if the patient is talking, we are able to see. But if the patient is not able to see, so we see a person who has come to us who is just lying on the stretcher. So we do not know what has happened to the patient, how he ended up being here. So our first job is to open the airway, see if there is any choking, or then start him on oxygen. So that is the airway. And as I said about airway and spine stabilization. So as I'm talking more on trauma, we see when the patient falls down, uh, he also, if he is in head trauma, we also assume that he might also have cervical trauma. So in order to maintain the airway and make sure that we do not touch his airway, we do not touch his spine, we do not if his spine is traumatized, there's a fracture in C1, C2 or C3, he might also have a paralysis of the lungs, because the nerve innervation of the lungs is of the diaphragm and lungs is done by the it is around the C2 and C3. So we have to make sure that we are not dislodging his cervical spine. We are making sure that we stabilize his spine. So it is done by the cervical collars. Most commonly, we use the Philadelphia collar. So maintaining the position of the head and spine and making sure he does not have any, he does not have any foreign body in the mouth and he does not have any blood or, sputum in the mouth is the one of the most important things. So that is when we talk about the airway. So for 90 of the percent the patients, if they come to us talking, we know that the airway is patent. Then we talk about breathing. Breathing, when we talk about breathing, we also talk about the breathing and the trachea. Is the trachea centrally, is the trachea deviated towards the right or the left? So, what is the significance of seeing the breathing and seeing the trachea? So, in breathing, the most important thing is we auscultate the lungs uh, for the vesicular sounds. If there is some crackles, we also think that it can what can be the pathology related to the crackles. And most important thing we see that is the air entry going on to the lungs. If we see a patient who has come to us with a trauma, why auscultating the chest is important, because we can think of pneumothorax, we can think of pneumothorax, tension pneumothorax. You can see that if there is some foreign body has been lodged in the chest, there is some stab injury. Because of that, there can be lung constriction. If there is blood trauma, we also have to see that is there any rib fracture. So we see the chest wall movements. We see that is there any additional sound that is coming from the lungs. We see the position of the trachea, because in tension pneumothorax, that's one of the most leading causes of, it's a leading killer in trauma patients with chest injury. We see that how is the trachea located. We also check the veins, the neck veins. Are they engorged or are they not engorged? So we want to make sure that the breathing is okay. So in order to maintain, if everything is okay, as I told you, there is no hemothorax, there is no pneumothorax. We are not doing any needle decompression to relieve those things. So we will just supplement the patient. Everything is okay on that. So we supplement the patient with oxygen. So that is the way we treat trauma patients. So basically, giving oxygen is not that the patient is desaturating. So any patient that has come with trauma, that means there is more need of demand is supplementing the oxygen does not only help in helping us to overcome hypoxia, but it also helps us to make sure that the patient is healing. So it is a part of treatment, not only to make sure that the patient is not desaturated. That is why in movies we see that the patient comes, they just put on the oxygen regardless of whatever there is. So that is, as I said, it's a protocolized approach. So airway, as I talked about, how we see that there is no foreign body. Breathing is checked by, as I told you, auscultation, and we supplement it with oxygen. In case there is some issues with the breathing, as I told you, there is tension in pneumothorax or pneumothorax. We do, as I told you, ICD placement. That is the most important thing, because if we, as I told you, there is a protocolized approach. So if we are okay with the airway, then we move on to the breathing. And once the breathing is okay, we move to the we move on to the circulation. So in circulation, we talk about, it's called circulation and hemorrhage control. Suppose a person is bleeding, he's bleeding to death. So what is the most important thing for us? So we have to control the bleeding. We control the bleeding by putting the pressure on it, by putting a pack on it, by putting a bandage on it. If we are not able to control with it, we'll put gauze piece inside. If there is a good amount of deep cut is there, we put the gauze piece in this. We try to control the hemorrhage by that. If we are still not able to do that in limbs, we can use a tourniquet. So that is the thing that we are talking about, bleeding in trauma patients. So circulation deals with the BP. So how is the patient's BP? How is the patient's urine output? That urine output is a very important marker of circulation. So we talk about urine output, we talk about the BP, we talk about pulse rate. So pulse rate is the patient. Suppose the patient has gone to a trauma and he's bleeding. If we see in tachycardia, if we see a lot of tachycardia, and we also see hypotension, that means the patient has bled enough. So it's a class C or class 4 injury. So that means he has bled enough, and he that will make us sure that we have, that is also give us a marker that we have to supplement blood with it, blood and blood products. The initial fluid of choice is, we can go with the crystalloids, IV crystalloids. So as an emergency physician, if we have to, our job is to make sure that the patient is vitally okay, and we stabilize the patient. Then we shift the patient to definitive care. Suppose it's a chest trauma, then CTVS or surgery, we look at it. If it's an abdominal trauma, again, then there's a liver acceleration, grade 3, grade 4. Then the surgeons will look at it. If we see that there is a pelvic fracture and the patient is bleeding through pelvis, then the orthoped will look at it. But before being treated by a specialist, we have to stabilize the patient. Once the vitals are okay, once we have the heart rate is okay, once the BP is okay, once the blood sugar, everything is okay, then only we can shift the patient to the OT or shift to the definitive care, no, the ortho team. So our job as an EP in seeing all the patients is make sure that the patient is stabilized. As I talked about the airway, how do we stabilize the airway? How do we stabilize the breathing and circulation? If the BP is decreasing, we give fluids. If it's not still being controlled by fluids, and we see a lot of trauma, we will go with the blood and blood products. So that is the thing. So then the disability. D is for disability. So A is for airway and cervical spine management. B is for breathing. C is for circulation and hemorrhagic control. D is for disability. In disability, we check the GCS of the patient. That is one of the most important things that we are taught in MBBS, to check the GCS. We also check the size of pupils. Are the pupils reacting to light or not? And along, once we are in disability, we also check the blood sugar. So we also check the blood sugars. So once we are okay with we saw the GCS. If the GCS is poor, like less than 8, we intubate the patient. So that is how we maintain the area of the patient. If the GCS is less than 8, if it's more than 9 or 10, we keep on checking serial GCSs every 15 to 20 minutes. So so that we actually deal with the patient. We see, is the patient deteriorating or improving. And in we also check in exposure and environmental. So in exposure, we make sure that the patient is properly, proper patient is undressed. If it's a female, we use a chaperone, and if it's a male, we undress the patient. We see if there is any external injuries. Suppose the patient has come, he's on the stretcher, and he has a back injury, back stab. So if you do not expose the patient and do a log roll. So log roll is the proper way of how we turn the patient and see if the back has any injury, if there is any injury with the spine. So we make sure that everything is okay, then only we again reassess the vital. So A, B, C, D, E, that's what I told you. Airway and breathing control. Airway, and C is cervical spine stabilization. B is for breathing. C is for circulation and hemorrhagic control. D is for disability, and E is for exposure. Once A, B, C, D, E, everything is stabilized, of that we again reassess. So we do a reassessment of all the three. Once again, we see all A, B, C, D is fine. We reassess the vitals. Then we go on for systematic approach. That is when that is we start with the sample history, and then we go for HEENT. So sample history, that we say that now some people also say it ample. Signs, what are the signs, what happened, what is the allergic history, what is the medication history, what is the past history, when was the last meal taken, and these kind of things. So once we deal with sample history, then we move on to the HEENT examination: head, eye, ear, neck, and throat. So a proper approach is there. So as I told you, once we are okay with the initial assessment, that is the primary survey, vitals are stabilized, everything is fine, then we go on to the systematic exam. That is we start with the sample history, and then we go for HEENT. So sample history, that we say that now some people also say it ample. Signs, what are the signs, what happened, what is the allergic history, what is the medication history, what is the past history, when was the last meal taken, and these kind of things. So once we deal with sample history, then we move on to the HEENT examination: head, eye, ear, neck, and throat. So a proper approach is there. So as I told you, once we are okay with the initial assessment, that is the primary survey, vitals are stabilized, everything is fine, then we go on to the systematic examination. In systemic examination, as I told you, we go with the sample history, then we go with the HEENT: head, ear, eye, neck, and throat. If that is okay, then we go into systemic examination, just like we do it in medicine: CVS, CNS, per abdomen. So why do we not directly jump to the systemic examination and go with the primary survey? Because we have to stabilize the patient first. Once the patient is stabilized, then only we can go for it. Definitely, then when we go through we stabilize the patient, and we saw that okay, the patient has a trauma, we went for the investigations of trauma. We saw that we went through the fast, and we saw that there is a fluid collection in the recesses, in any of the recesses. Then we go to the specialist, and then they decide how to deal with that. Does that person need an immediate OR? We take to the operating room, or does the patient need to be taken to the ICU for close monitoring and for being treated properly, or does the patient need to go ward for, as I told you, for further treatment, or the patient, as I told you, do we need to refer to do we need to uh, discharge the patient? So we also have to look at all those aspects if any of the trauma comes to us. So you can ask me any questions now you feel right about it. Yeah. This is what I told about the basic. This is how we do the primary survey of all the patients, and particularly about the trauma that comes to us emergency. So this is the emergency medicine approach to a patient. It is universalized in all the patients around the country. So around the country, around the globe. So every emergency physician that the patient will come to us, this is the basic protocol that he will be following. So there is nothing. Because patients, we are taught how do the medicine people deal with the patient, how ortho people, because we have those posting, but we do not have, we never have had emergency medicine posting. So this is the approach to a patient that an emergency medicine physicians takes. And during the course, he will decide what investigations are needed, what primary investigations, just X-ray, blood sugars, and fast. We have a fast that we do in the emergency. Pelvic X-ray, chest X-ray. Even if there's a head trauma, this is poor, and he has a history of vomiting, nausea, EMT bleed. We go for the CT scan. So this is the investigations that we most of the time deal with as an emergency physician. We are in constant contact with radiologists. Once we feel what is the, we come to a definite diagnosis. We involve the speciality that is that deals with it. So as I told you, if it's a blunt trauma to the abdomen or a penetrating trauma, the surgeon will be able, we have to directly make a call to the surgeon, make him understand that he has to come to the ER and see the patient, how, tell him the grade of injuries, tell him what do you suspect, what should be the future plan. So it's a multidisciplinary approach that we have in order to deal with the patients that come to the ER anytime.
That was really informative, sir. And my question is, if a patient appears stable after the history of trauma, is it still necessary to calculate the GCS and then carry out all the routine investigations as you
Uh,
stated?
so So now there's the question, what do you mean by stable? If you mean the patient is vitally stable, as I told you, any patient coming to the ER, we will go with A, B, C, D, E approach. So we see the patient is talking properly, we'll be happy with that. Okay, his airway is patient. We auscultate, lung sounds are clear and everything is fine. We do a chest compression test, everything. We see that there is no trauma and everything is fine, that there is no respiratory distress, the respiratory rate is normal, breathing pattern is normal. So we are okay with the breathing. So we do it double tick one. We see that the BP is normal, urine output is normal. So in circulation, we see everything is normal, as I earlier told about it. In D disability, we see everything is normal. Okay. And if we see everything is normal, so we will go through the approach. If we see everything is normal, we check, and then we go with the systemic examination. If we see everything is normal, check. Then we will decide that the patient need to go home. We'll give some medicines for which primary complaint he has come, or he needs admission. As I told, we'll if there is some specialty that needs to be involved, we will involve the specialty. So by just the look of it, we cannot say that the patient is normal. Suppose the patient has fall down, it's a baby, 2-year-old baby, he fell down from the bed. So he'll not be able to tell. He will not be able. So we have to observe sometimes, observe the patient for 24 hours to make sure that everything is fine. If the patient has to be sent home, we also send the home with the things that they have to, they have to check at home. So the baby is talking, he's playful, he's having milk, he's not vomiting, or he's not getting dizzy. So we have to make sure if we're sending the patient and we see that he has fallen down and he looks normal. So what we suspect that can happen, we have to educate the patient about that and have to send him with a checklist that they have to tell them that they have to come to the ER if you sense anything. So seeing everything that you might say is normal cannot be normal. The patient has met through a blunt trauma, somebody punched him real hard, or he fell down from it. There is no external injury. You do not do an ABCD approach and you see that the patient is totally fine walking, and next after 3 hours he'll be like coming to the ER with excruciating pain and with bad vitals. So we have to do an ABCD approach. Once that everything is clear, then only we'll have to say, okay, the patient is normal and he needs to go home or not. As I told you, once he has a blunt trauma to the abdomen, there is a liver laceration, there is an intestinal laceration, and we did not palpate it. He looked normal, came to us normally, but he said this happened. We did not palpate, so we'll be missing it. So we have to have the protocol approach, ABCD approach, primary survey, HENT sample, and then systemic approach. Once we are everything is okay, then we say yes, he is normal and he's good to go home. So that is the thing. So once we do not go with the protocolized approach, we will be missing something. And as an emergency physician, it is your job not to miss something. 99% of the persons will be caught, but that 1% that will not be caught, you have to catch that thing. So that is what that is why you are an emergency physician, and you have to deal with that in your day-to-day life.
Okay, sir. Then the second question was, if we are staying in a peripheral center and there's a patient who's come with a history of trauma and there's no specialized facilities available in the center. So what would be the initial approach in the management, and should we refer the patient or should we manage in the same center itself?
So it's a very important question. As I told you, in ATLS, we are also taught that how to refer a patient and what you have to do. So firstly, the patient comes to us, his GCS is 8, suppose he has a very bad head trauma, bleeding to death. and he has come to us as a periphery, and I'm at a periphery. Just say that at a community hospital that does not have the basic sources. So firstly, my job is to get the IV line, uh, start a drip, start maintain, take his vitals, make sure. So your job is to, if there is no speciality for you that is going to take care of. Suppose he's in head trauma and needs neurosurgery, but that does not mean that you do not have to see the patient. You have to see the patient. You have to do the primary survey. You have to do the A, B, C, D, E. Once you do the A, B, C, D, E, you stabilize the patient. That and the next hospital, suppose that's like 40 kilometers apart. You ring up to the hospital. May talk to the specialist. That is just introduce yourself. That hi, I'm Dr. Umar. I'm dealing with a trauma patient that has come to us. We see that he's bleeding. We have controlled the bleeding by gauze bandage or by putting a tourniquet. We have his BP was dropping. We have given him, because that is fluids will be there. If you are a PHC or any accommodation, there will be IV access. There will be fluids. So we have maintained we're maintaining his BP was he was getting hypotensive. We have started him on 1 liter fluids, colloids, crystallized 1 liter crystallized 1 liter, and we have started him. So we are maintaining his BP. As I told you, maintaining the airway, you check him, there is any foreign body, you take it out. And then in breathing, you start with the oxygen. So it's very basic. It will be at all the hospitals. So oxygen you started, airway you check that there is nothing, oxygen you started, in circulation if there is any trauma anywhere, you stop the bleeding there, right then and there. And then you start with the IV fluids. If there's a BP is decreasing, then you start. And then, as I told you, then you go for the ABCD approach. You do not need a lot of limit. You do not need a lot of instruments and a lot of things to deal with it. So as I told you, Dr. James Steiner, who started the ATLS, his wife died because she was mismanaged at a hospital that did not have a protocolized approach. So then he went on that I'll make a protocolized approach that should be followed throughout the whole world so that no patient should be mismanaged. So this ABCD approach was made in looking at the limitations that some hospitals have. And this ABCD approach can be done by any hospital, even though it's not it's a peripheral hospital. So that is why when you see you are work at an ABCD center or a higher center, district hospital, so you see the patient will always have an IV. The patient will be with an oxygen mask. So basic things you have to maintain, because if you do not maintain, he's bleeding from a source. You do not control to the bleeding, he will not reach to that hospital. He'll be bleeding midway. So you have to stabilize the patient. Stabilize, as I told you, how we stabilize the airway, how we take the breathing, then start with the fluids. This is the basic things that you can do. And transportation is one of the most important things. If suppose there are three hospitals at a distance of 10 kilometers each, you have to talk through the hospital that will have the speciality that will serve the purpose. He might need neurosurgical intervention. So you talk about it to the doctor. If they have a neurosurgical surgery on call, they'll prepare the necessary means for that. If the patient needs to go to the OT, they'll prepare the OT. So communicating the same thing, the your patient to the referring facility, the facility that you are referring, you should communicate it to them properly, and you should tell them what you have done, a brief summary, 3 to 4 lines, what you have done, what he came with, what you have done, what you anticipate can happen, what you think needs to be done, and what you think needs to be done, what do we expect, can go wrong. So while shifting, then he says, okay, I'm good to go. We are here. We have prepared we've called in the neurosurgeon. You can send the patient. Most important thing is transferring. You have to transfer the patient. You have to look for the supplies that can be used during the transfer process. And you have to also see that we have a doctor or some EMS that transfers the patient. As I told you that if you do not have if you do not have enough fluids with yourself, then BP might drop midway and you will have nothing. So you have to see the supplies that are going to be taken. So that is why we do with, we mostly go with ACLS ambulance that has an advanced cardiac life support. So we'll make sure that if he goes through arrest or any other cardiopulmonary event, we deal with that. And so the transportation is very important. Knowing that your hospital does not have the facility that will definitely deal with that. If there is a trauma to the leg, you do not have an condition, you stabilize him. ABCD approach, stabilize, input, traction, splint, whatever is needed, then shift to the shift to the higher center. So that is the thing. So you have to talk to the higher center. You have to talk to the doctor you're referring to. You have to make a proper summary of that. So in our country, we do not have the habit of making a proper summary. You have to also give a transfer summary. So there's a proper way of writing a transfer summary. So once you deal with that, you can shift because there is reason to hold up the patient. You cannot hold the patient. अभी CT इसका नहीं हुआ, X-ray नहीं हुआ, तब जाके hold करेंगे. अगर आप CT X-ray करोगे, you're doing a CT and X-ray. Still that you can't do nothing because you do not have the resources to do it. That's better to stabilize the patient and send to the higher center that do have specialists to deal with that kind of emergency. For that, I told you what is the thing that you need to communicate to the doctor you are sending, the center that you're sending. You have to make a wiser decision. Where do you send? Do they have a specialty? Otherwise, you some people in India, you send okay, यहाँ पे नहीं है, आप दूसरे hospital भेजो. That hospital might not have the resources, so they will be roaming throughout the whole day. Patients used to come to us, they have roamed the whole day and then came to us, went from hospital to hospital. So because they were not informed about it. So it is basically the doctor who sees the patient at first, make sure that the patient is sent to the right place for the management so that precious time is not lost and he reaches the definitive management. And the golden hour we say in trauma, so we have to make sure that the patient, within 1 hour, most of the deaths happen. If the patient comes to the hospital within that time, we are able to manage it more properly and it has a more survival chance. Even as you say in MI, door to needle time, door to balloon time, we want to make sure it's at least like 90 minutes for door to balloon. So we make sure the patient goes to the higher center, tertiary center, the definitive center as soon as possible and no time waste because of some investigation and because of some traffic or not able to communicate it to the doctor properly. So that should be the main thing, and this is how it should be dealt with. We do not have enough trained doctors to deal with this kind of transfer summary, but yeah, our country is picking up on that, and we are getting better for sure. Any questions?
That was a pretty important question which you answered right now, sir. No, sir, I don't have any more questions. It was a pretty informative and elaborate yet concise session. Yes, sir.
So actually, finally, I would like to add that the most important thing is how an emergency medicine doctor sees the patient and how the protocolized approach is that. So it is more like a head-to-toe examination. What can go wrong? So you will be missing less likely things if you go through the protocolized approach. And once you follow the protocolized approach more and more, and it will be very fluid with you, and you will be making less errors, missing less things, and we'll have a better outcome in dealing with the patients.
Yes, sir. Thank you for this wonderful session, sir.
Thank you for hosting me.
Yeah.